بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, now we will continue the topic of imaging of bone tumors, and we have classified the bone tumors into three main groups. The first group was that where the tumor is can be spotted from the plain X-ray or CT or MRI, and it has almost no differential diagnosis. And we came now to the second group, which include lesions with suggestive imaging features. And these lesions include osteosarcoma, Ewing sarcoma, chondrosarcoma, aneurysmal bone cyst, simple bone cyst, metastatic deposits, multiple myeloma, and chordoma. Starting by the malignant criteria, which are quite different from the benign criteria we have mentioned before. And you remember that the benign criteria include an expanding lesion with sclerotic margin, no perosteal reaction, no extraosseous soft tissue component. And here the malignant criteria are almost the opposite. The lesion is destructive. There is an ill-defined margin. There may be, or they always, or sometimes you can see perosteal reaction as well as extraosseous soft tissue component, and consequently this extraosseous invasion may invade the neurovascular bundle or the adjacent joint. On top of this group is the osteosarcoma, which is one of the known primary malignancies of the bone. About 50% of the lesions arise around the knee, and it may affect different bones in the human body. This lesion is in the metaphyseal pathology. It is usually associated with bone destruction and sometimes bone sclerosis, and very commonly you can see this very characteristic perosteal reaction, which is known as the sun ray speculations. And you can see this sun ray speculations, and one of the features also of this tumor is what is known as the Codman triangle. And this is what we mean by the Codman triangle, which is an elevated perosteum at or near the edge of the tumor, forming this almost characteristic triangle, which can be seen on either side of the bone. And this is the classic X-ray of an osteosarcoma involving the distal part of the femoral shaft. And you can see the very characteristic periosteal sun ray speculations. You see the cortical erosions and permeation by the tumor, and you can also appreciate the degree of bone sclerosis as well. And this is also a case of osteosarcoma of the proximal tibia. And you can appreciate the degree of dense sclerotic reaction of the tumor matrix. You can also see the characteristic sun ray speculation. You can appreciate the Codman triangle, and of course you can feel the existence of the extraosseous soft tissue component. Here the tumor does not invade the physis, and it does not involve the epiphysis, as you can see from this plain X-ray. And this is another example of an osteosarcoma of the proximal fibula. And you can see the degree of bone destruction. You can see the perosteal reaction, sun ray speculation, matrix calcification of the tumor, and the huge extraosseous soft tissue component. Of course, bone scan will show increased uptake of the in the region of the tumor, and the X-ray can show the degree of cortical destruction, the periosteal reaction, and gives you an idea about the degree of extraosseous soft tissue component. But this component is well appreciated by the CT scan and also by MRI. And one of the features is not pathognomonic, but one of the features of osteosarcoma is that the extraosseous soft tissue component is usually eccentric in location. It does not circumferentially surround the bone, similar to the Ewing sarcoma, but most of the osteosarcomas will have an eccentric soft tissue component outside the bone. And you can see the periosteal sun ray speculations, also the matrix calcification of the tumor. And this is an example of osteosarcoma of the proximal humerus by plain X-ray. Here you can see the degree of bone sclerosis. Also, the tumor is associated with pathological fracture. By MRI, you can appreciate the degree of bone marrow invasion. All the shaft of the humerus up to this region is infiltrated by the tumor. The epiphysis is not involved, and there is a good amount of extraosseous soft tissue component, and you see the pathological fracture. In the axial images, you can appreciate that the extraosseous soft tissue component in most of the cases is usually eccentric in location, and it does not involve the whole circumference or surrounds the whole circumference of the involved bone. This is also an example of osteosarcoma by X-ray and MRI T2-weighted image. The tumor and the extraosseous soft tissue component is appreciated because of the periosteal reaction and the tumor matrix calcification. And in MRI, you can appreciate the degree of bone marrow infiltration, and also you can see the extent of extra soft tissue component, which is more than that appreciated in the plain X-ray. And the plain X-ray can see the extraosseous soft tissue component up to this limit, but in the MRI, and this is one, of course, of the advantages, and you can see the extent of the tumor. The second tumor in this group is the Ewing sarcoma, and the Ewing sarcoma is classically a diaphyseal lesion, arises in the diaphysis of the bone, and one of the important features of Ewing sarcoma is bone sclerosis. And here you can see that there is a sclerotic tumor infiltrating the mid shaft of the femur with loss of the corticomedullary differentiation. And one of the important features in Ewing sarcoma is the lamellated or onion peel periosteal reaction, which is clearly seen in this particular case. Then be careful that Ewing sarcoma may clinically simulate osteomyelitis. This tumor is very vascular. Then whenever it involves the tibia, for example, the leg will be swollen, it will be hot, it may be red, giving similar criteria of inflammation. And the changes of Ewing sarcoma may be subtle in the plain X-ray and may be mistaken for osteomyelitis. Then be careful of this. One of the features of Ewing sarcoma is the periosteal reaction, which is lamellated. And you remember, the periosteal reaction of osteomyelitis is candle wax, similar to the candle wax, but this is lamellated onion peel periosteal reaction. Also, you cannot see the rest of the manifestations of osteomyelitis like sequestra and the cloaca and new bone formation outside the original bone. But here you can see the permeative cortical destruction in the region of the tumor, and you can appreciate also the periosteal reaction. Then if you see this, and this is one of the examples, bone sclerosis, cortical erosions, loss of the corticomedullary differentiation, and lamellated periosteal reaction, then you may need the help of MRI in particular because it is the most sensitive technique for evaluation of bone marrow infiltration. Then, if you look carefully to this pelvis and the proximal femora, do you think the lesion is on the right or on the left? If you look carefully, then you can see that this femoral head is not of normal density, and also you can see that there is or there may be some soft tissue swelling here, and this is the CT and MRI of the same case. The CT shows cortical erosions, shows circumferential periosteal reaction, and the MRI shows a good part of bone marrow invasion, being of low signal in the T1 and high signal in the stair-weighted images. Remember that the changes of Ewing sarcoma may be subtle in the plain X-ray and may be easily missed in the plain X-ray if you are not careful in looking for the manifestations, guided by the clinical picture of the patient. And in this plain X-ray, you can also see that the proximal tibia is relatively sclerotic with loss of the corticomedullary differentiation, and in the coronal MRI, there is a large tumor invading the bone marrow over a long segment of the proximal tibia associated with extraosseous soft tissue component. Then here in the pelvis, and what do you think? Do you think that the lesion is on the left or here or on the right? Okay, let us look at the CT and MRI. The lesion is involving the iliac bone on the right side. Go back to the plain X-ray. This is the iliac bone, and this is the left iliac bone. If you can look carefully, then you may feel that this iliac bone is relatively dense or sclerotic compared to this iliac bone. And this is because of the presence of considerable soft tissue component which is located along the inner aspect and the outer aspect of the iliac bone. Then this was proved to be an Ewing sarcoma of the right iliac bone. The third tumor is the chondrosarcoma, and chondrosarcoma is diagnosed by the presence of malignant criteria as well as matrix calcification of the tumor. Then, what are the malignant criteria? Bone destruction, extraosseous soft tissue component, periosteal reaction, so on and so. And this tumor is arising from the rib, and the rib is destroyed. There is a good or a big extraosseous soft tissue component with matrix calcification. Then you think of chondrosarcoma. And here, a chondrosarcoma arising from the sacroiliac joint, and there is a soft tissue component inside the pelvis and another soft tissue component outside the pelvis, and you can see the matrix calcification within the tumor tissue. Chondrosarcoma of the sacrum is or of the spine in general is uncommon lesion compared to other common lesions affecting the spine. I will discuss this in details in the lecture of spinal tumors. And this is an example. You see a big soft tissue tumor which is infiltrating the sacrum with a component outside the pelvis and another component inside the pelvis. One of the drawbacks of MRI, as you all know, is that its inability to show matrix calcification as good as the CT scan. Then one of the criteria of chondrosarcoma is to see matrix calcification in order to suggest the possibility of the tumor. You remember that chondrosarcoma may arise primarily from the bone or may be on top of a pre-existing lesion, and these lesions include enchondroma in cases of Ollier disease and Maffucci syndrome, as well as the osteochondroma in cases of multiple osteochondromatosis or diphyseal achalasia. You remember that in the solitary enchondroma, the incidence of chondrosarcoma in a solitary enchondroma is about 1%. But when the enchondroma is multiple, as in Ollier or Maffucci syndrome, then the incidence of chondrosarcoma will raise up to 30%. And so also the case in cases of osteochondromatosis. You remember that to predict malignant transformation in an osteochondroma, and you look for the thickness of the overlying cartilage cap. And the normal thickness is usually a few millimeters. If the thickness is 1 centimeter or above, then you think of malignant transformation of the osteochondroma. Also, you can look to the cortical bone underneath the cartilage cap, and you will see significant bone destruction and erosion, which is also one of the criteria of development or malignant transformation. Then we came to an aneurysmal bone cyst, which is a benign lesion and is seen usually under 30 years of age. And this is an expanding lesion which is multilocular, and one of the most common diagnostic criteria of this tumor is the presence of fluid levels. In the books you will see that fluid levels may occur in many of the lesions, but this aneurysmal bone cyst, fluid levels are very characteristic for the diagnosis of aneurysmal bone cyst. Aneurysmal bone cyst of the calcaneus, for example, this is an expanding lesion which is multilocular with internal septations, and the fluid levels can be seen by CT but very well appreciated on MRI, and you can see these fluid levels depending on the different contents of the cystic components of the lesion. Aneurysmal bone cyst is one of the lesions seen in the spine, and it affects usually the neural elements, and if it is large, it may go into the vertebral body. And this is an expanding lesion, as you can see, and that by CT you can appreciate the fluid levels, but MRI is good in this particular domain. And here is an example of a big aneurysmal bone cyst affecting the left side of the vertebral body as well as the neural elements with characteristic multiple fluid levels, as you can see here. Aneurysmal bone cyst of the distal femur, and then the T2 weighted images and also in the T1 weighted images you can appreciate the presence of multiple fluid levels, which are very helpful in suggesting the possibility of aneurysmal bone cyst. The simple bone cyst or unicameral bone cyst is a cystic lesion which is unilocular. It does not contain multiple loculi. And this cyst commonly occurs in the proximal humerus and the proximal femur. 90% of these lesions occur in the proximal femur or in the proximal humerus. Then if you see an expanding lesion in these particular two sites, the first possibility will be a simple bone cyst. Then the only thing to support your diagnosis is to confirm that this cyst is a single cavity. And sometimes in the x-rays they show pathological fracture, and one of the fragments of the bone will sediment at the dependent part of the cyst, indicating that this is a unilocular cystic lesion. Then by plain X-ray, sometimes you cannot appreciate the single cavity of the cyst, and you may need the help of CT or MRI. And you see here, this is a simple bone cyst in a characteristic common location, which is the proximal part of the femur. And here is the simple bone cyst in the proximal humerus, and a simple bone cyst in the proximal part of the femur in another case. Then metastatic deposits are usually multiple. They affect the skeleton. The lesions may be osteolytic, may be osteosclerotic, may be mixed osteolytic and osteosclerotic. Usually, you do not see perosteal reaction in cases of metastatic deposits, but if the lesion affects one of the long bones, for example, you may see pathological fracture. One of the helpful criteria for the diagnosis of metastasis is the presence of non-primary malignancy. But in cases of multiple lesions like this in the spine, I will emphasize this in the lecture of spinal tumors, then the first possibility whenever you see multiple infiltrative bone marrow lesions, especially if they are of different sizes and they affecting the neural elements, then you think of metastatic deposits. And this is also a characteristic appearance by CT scan of metastasis in the pelvic bones as well as in the sacrum. Of course, you know that bone scan is one of the most sensitive techniques searching for metastatic deposits, and you can see the extent of metastasis by this simple technique. Also, you know the differential diagnosis of a solitary dense vertebra like this one. This dense vertebra may be one of three: either a sclerotic metastasis, or maybe due to lymphoma or Paget's disease. And you know that Paget's disease will enlarge the size of the bone. Then look to the sclerotic vertebra. If it is similar to the above vertebra or the below vertebra, then you can exclude the possibility of Paget's disease. Then you are in between these two diagnoses, deposits or lymphoma. Then this is an X-ray of the pelvis showing multiple osteolytic lesions of the iliac bones, of the proximal femora, of the pubic bones, and also of the spine, representing metastatic deposits. And metastasis can also be sclerotic, and whenever the sclerotic metastases are mentioned, you remember the prostatic cancer, which is one of the commonest lesions to give a sclerotic metastasis. But remember also that the breast and lung cancer may present by sclerotic metastasis or even mixed metastatic deposits. And you also remember that metastasis may be lytic at the start of therapy and may turn sclerotic by during the course of radio or chemotherapy according to the treatment. This is an example of sclerotic metastasis of the dorsal and lumbar vertebrae. And you see this deposit, which involves the whole body of the vertebra as well as the pedicle and the lamina. Also, you can see these multiple lesions. And you remember that the bone island is a sclerotic lesion which may be mistaken for a sclerotic metastasis, but the edge of the bone island is speculated, while the edge of the sclerotic metastasis is usually smooth, as you can see here. And whenever you have the possibility to reconstruct the images in sagittal or coronal way, this is very helpful, especially in the follow-up of the lesions, because in the single image you can know the level of the metastatic lesions, and you can compare this image by the recent image to see the response of therapy. Then one of the most important, let us say, is something to important for you to remember is the most sensitive pulse sequence to see vertebral metastasis is T1 without contrast injection. And this is an example by sagittal T1, sagittal T2, and sagittal T1 post contrast. Then look here and you can see you can easily appreciate the metastatic lesions in different vertebral levels. But in the T2 weighted image, the appreciation of metastasis is less because in the T2 weighted image, metastasis will start to raise up the signal, and the bone marrow will decrease its signal because it contains fat. Then you have the possibility to miss or to be unable to appreciate very well the presence of the metastatic deposits. Also, if you inject contrast, then metastatic deposits will enhance, and whenever they enhance, they will have a bright signal which will be masked by the bright signal of the fat in the vertebral body. Then this is not a good policy to inject the patient with gadolinium in cases searching for metastatic deposits, because metastases are very well appreciated in the T1 weighted images before contrast injection, especially in the sagittal plane, as you all know. Then whenever the metastases are sclerotic, they will appear black in the T1 and also black in the T2 weighted image, and many times they do not enhance with contrast. And this is an example of sclerotic metastasis in the first two sacral segments in the T1 weighted image and the T2 weighted image, and after injection of contrast. You also see the extra osseous soft tissue component inside the spinal canal, as well as in the valves. Then what are the features that can help you to suspect the possibility of metastasis? Number one, if you have multiple skeletal lesions, especially if they are mixed and of variable size, because the lesions of myeloma are usually small and are almost of equal size and are usually lytic lesions. But if you see lytic and sclerotic, or you see sclerotic lesions and the lesions are of different sizes, then you know that you are dealing with metastatic deposits. Number two, if you see a destructive lesion in the vertebral body without affection of the disc space, because you know if there is destruction with involvement of the disc, you are dealing with an inflammatory lesion in the spine. But if there is destruction without affection of the disc, this most likely suggests the possibility of metastatic deposit. And you may say that what about the primary tumors of the spine? And you know that metastasis is by far the most common malignant tumor of the spine. Then whenever you see a destructive lesion in the vertebral body without disc space affection, think of metastasis. And a good policy to follow here: don't go for bone scan, don't go for any other imaging modality, but go direct for biopsy. If you see this lesion, destructive lesion in the vertebral body, go direct for biopsy. Number one, to confirm the diagnosis. Number two, to know the primary site. And this is an important issue. Then if you see osseous lesions as well as metastasis in the lung, metastasis in the liver, this will support your diagnosis. And also if you see a destructive lesion in the iliac bone in an adult, I suggest for you, if you see a destructive lesion in the iliac bone in an adult, think of metastasis. If you see a destructive lesion in the iliac bone in a child, think of Ewing sarcoma. And also a good policy here is to go direct for biopsy to confirm the diagnosis and to know the primary site. And this is another female patient with a very big destructive lesion in the iliac bone that represents metastatic deposit. Then multiple myeloma is the primary malignant tumor of the bone. It represents 1% of all malignant disease, 10% of hematological malignancies. And these lesions are classically osteolytic, and they are most commonly of similar or almost similar size. And if you look here, there are multiple osteolytic lesions in the femoral shaft, and multiple osteolytic lesions in the calcareal bones, and multiple osteolytic lesions in the vertebral body, as well as in the iliac bones. And if you see lesions like this, you are in the differential diagnosis between myeloma and metastasis. And if you know the primary malignancy, this will help. If the lesions are mixed, sclerotic and lytic, this will help. If the lesions have a good extraosseous soft tissue component, this will help. It is in favor of metastasis rather than multiple myeloma. And this is a classic case of myeloma, where you see numerous osteolytic lesions of almost equal size affecting the pelvic bones as well as the proximal femora, most of the vertebral bodies, as well as the ribs, as you can see here. Then the solitary myeloma, as you all know, is known as the plasmacytoma, and multiple myeloma will appear as numerous osteolytic lesions of almost uniform size. They may coalesce together to form a large lesion. In the plain X-ray, you may appreciate only, especially in the spine, that there is osteoporosis and some vertebral collapse. And here is the same case of myeloma I have presented before, and this is the skull of the same case, and also a close look for the lumbar spine and the rib lesions as well as the pelvic lesions. And in the spine, you can see that there is loss of bone density, and there are multiple loss of height of the vertebrae, and this may be normally seen in patients with osteoporosis only. But in order to confirm that this has a relation to myeloma, you should have CT or MRI. And if you have the CT scan and you see multiple osteolytic lesions of almost equal size affecting the vertebral bodies and the neural elements, then you think of myeloma. And in MRI, you can see that the lesions are of low signal in the T1 and increased signal in the T2 weighted image. And you will appreciate multiple variable degrees of loss of the vertebral height. The chordoma, which is the last one in this group, as you all know, affects the ends of the vertebral column. 50% will be seen at the sacrococcygeal area, 35% will be seen at the spheno-occipital area, and 15% will be seen at other sites in the spine and even in the paracellular area, as I will explain after that. Then this is the most common primary malignant tumor after lymphoproliferative tumors. It arises from remnants of notochord, usually a midline lesion. It forms a large mass with matrix calcification and destruction of the affected part of the spine. And the previous example is a destructive lesion in the sacrum with some expansion and extraosseous soft tissue component. And here also you can see a destructive lesion with an extraosseous soft tissue component. Actually, the chordoma may have similar appearance to metastasis, but considering the location, considering the matrix calcification, considering the absence of known primary malignancy, you may suspect the possibility of chordoma. And also, one of the best diagnostic criteria of chordoma is MRI T2 appearance. In MRI, the chordoma will have a very bright signal in the T2 weighted images similar to water. and this may help you. This is not the case, of course, in metastasis. You remember, metastases are hardly seen in the T2 weighted images, but chordoma will show bright signal similar to fluid in the T2 weighted images. And this is an example of destructive lesion in the sacrum associated with extraosseous soft tissue component and matrix calcification, highly suggestive of chordoma. Finally, we came to the last group of lesions which have no imaging, specific imaging features, and this include the fibrosarcoma, fibrous histiocytoma, chondromyxoid fibroma, adamantinoma, and lymphoma. Starting by the fibrosarcoma, and this is the least common malignant bone tumor, and about 80% of the lesion occurs around the knee joint. All what you can say that this is a malignant lesion based on the malignant criteria: cortical destruction, extraosseous soft tissue component, perosteal reaction, so on so. But which one of the bone tumors is this one? You cannot predict the nature. You may say that this is metastasis. You may say that this is fibrosarcoma, and you can suggest only that this is malignant lesion. And here you can see there is a destructive lesion in the shaft of the third metacarpal, and this destructive lesion is associated with extraosseous soft tissue component. Then what do you think about this? And you cannot predict the nature. This is malignant tumor, of course, and it has been proved by biopsy to represent a fibrosarcoma. This is another example of a malignant lesion in the distal femur. Destruction, perosteal reaction, and you may feel that there is some extraosseous soft tissue component, and these are malignant criteria. You need biopsy to go to reach the diagnosis. The chondromyxoid fibroma is a benign lesion, and it occurs in the metaphysis. And you should be careful because this lesion is an expanding lesion. It has a sclerotic margin. It does not reach the articular surface. Because if this lesion has reached the articular surface, then you may think that this is a giant cell tumor, for example. But you remember that giant cell tumor does not have a sclerotic margin. This lesion has a sclerotic margin. It may contain calcium because of the chondromatous part of the lesion, and it has no malignant criteria. But if you excise this lesion, it may recur if it did not excise totally, for example. Then this lesion is usually seen after epiphyseal closure. If it is seen before epiphyseal closure, and you may feel that the lesion is in the epiphysis, you may think of chondroblastoma, which is not the case. Then in this case, you see the tumor which is reaching the articular surface, and the lesion is expanding. You have the right to diagnose this as giant cell tumor, but this tumor has been proved histologically to represent a chondromyxoid fibroma. Then you know that there is some overlap, and because this tumor is classified here in the last group, because in many cases you cannot predict its nature unless you have biopsy this lesion. Adamantinoma occurs in two main sites in the human body, in the tibia and in the mandible. In the tibia, if it has the characteristic location and the appearance, you can predict the nature of the tumor from even the plain X-ray. This lesion affects the anterior part of the tibia. It is of mixed texture, osteolysis and sclerosis, and it will result in abnormal bowing and the characteristic shape of the tibia. If you see this, you may predict the nature of the tumor. As I have said, there are two skeletal locations for adamantinoma: the tibia and even the fibula, and also the jaw. The age incidence is about 20 to 30 years old. Then we came to the primary lymphoma of the bone, and you remember that I have said if you are confronted by a sclerotic, solitary sclerotic vertebra, think of deposit lymphoma and Paget. You can exclude Paget by the appearance of the vertebra or the size of the vertebra. If it is similar to the above or below vertebra, then you know that this is not Paget, and you think of deposit or lymphoma. Then lymphoma represents about 2 to 3% of malignant bone tumors, and it represents about 5% of extranodal lymphoma. And one of the pathognomonic features of lymphoma is bone sclerosis. Lymphoma may cause erosion and the destruction of the bone, but the sclerosis is one of the prominent features of lymphoma of the bone. And here is a sclerotic lesion in the proximal part of the tibia. There is no periosteal reaction, there is no extraosseous soft tissue component, and the patient is adult after epiphyseal closure. And if you have the MR of this lesion, it will show diffuse bone marrow involvement by a low signal lesion in the T1 and high signal lesion in the T2 weighted image. And if you see a lesion like this by MRI and you appreciate sclerosis from CT or X-ray, you think of bone lymphoma. And here is lymphoma of the proximal part of the humerus. Look carefully for the sclerotic reaction within the head of the humerus, and by MRI the diffuse bone marrow infiltration, which shows low signal in the T1 and high signal in the T2. Lymphoma of the iliac bone may show sometimes a characteristic feature, which is encasement of the iliac bone by a soft tissue component. The iliac bone marrow is infiltrated by the tumor. It will show high signal in the T2 on STER images, and the extraosseous soft tissue component looks like a sheet encasing the iliac bone, which is not usually seen in cases of metastasis. Metastasis destroys the bone. It forms a big extraosseous soft tissue component. By CT, you can appreciate the sclerotic reaction together with the permeative erosive changes of the affected bone. And this is what I have said. You see this iliac bone is infiltrated by lymphoma. The extraosseous soft tissue component is almost encasing or framing the affected bone. Lymphoma of the vertebrae may present as a sclerotic lesion and may present as an osteolytic lesion, and sometimes you can see vertebral collapse like this one. And actually you see here the degree of bone sclerosis and also the degree of vertebral collapse, which is also appreciated in the MRI with a significant encroachment on the spinal canal. Then diffuse bone marrow involvement of L5 vertebral body associated with extraosseous soft tissue component inside the spinal canal and retrospinally. This is the T2 weighted image, and this is T1 post contrast with homogeneous enhancement of the tumor and its extraosseous soft tissue component. And this is lymphoma of the femur on the right side. There is an infiltrative mass affecting the femoral head and the neck, and the mass showed the intermediate or low signal in the T1 and the increased signal in the T2 weighted images. Finally, the benign lesions of the bone are characterized by the well-defined margin, the sclerotic rim, and the expanding nature. And I put a question mark here because there are some malignant lesions that can show expansion, like plasmacytoma and some types of metastatic deposits. The benign lesions are not surrounded by extraosseous soft tissue by periosteal reaction, and there is no extraosseous soft tissue component. And this is the trial to collect the expanding lesions of the bone, whether they are tumors or not, include the word phygnomachic. This phygnomachic represents the fibrous dysplasia in chondroma, giant cell tumor, non-ossifying fibroma, osteoblastoma, myeloma, aneurysmal bone cyst, simple bone cyst, brown tumor of hyperparathyroidism, and hydatid cyst in cases of infection, and finally the chondroblastoma. Malignant features include ill-defined margin, cortical destruction, perosteal reaction, extraosseous soft tissue component, which may extend inside the joint and which may also involve the neurovascular mold. The classification of bone tumors in the books are represented in this way. They usually say that there are three main cell types in the bone: the osteoblast, the chondroblast, and the fibroblast. Tumors arising from the osteoblast include osteoma, osteodeosteoma, and osteoblastoma. The malignant form is osteosarcoma. Tumors arising from the chondroblast will include enchondroma and chondroblastoma, with the malignant component is the chondrosarcoma. Tumors arising from the fibroblast includes fibrous cortical bone defect, non-ossifying fibroma, and fibrous dysplasia, with the malignant component is the fibrosarcoma. And there is an intermediate lesion between osteoblast and the chondroblast, which is the osteochondroma or the cartilage cap exostose, and an intermediate lesion between the chondroblast and the fibroblast, which is the chondromyxoid fibroma. Then the remaining two groups, which are not classified under these titles, include multiple lesions, mainly multiple myeloma, metastasis, and lymphoma, and expanding lesions like simple bone cyst, aneurysmal bone cyst, and the giant cell tumor. هذا وبالله التوفيق والحمد لله رب العالمين. Thank you very much.